attention.
Thank you, Professor Tommaso, for your excellent presentation. It's my honor to present my dear friend, Professor Tamer Fekrey. He will talk about the completely carbon dioxide EVR.
Thank you, Mr. Chairman. I would like to talk about CO2 completely CHEVAR. So CO2 was mentioned in the literature and many studies talking about its scientific principles and practice and its use as a contrast agent for intravascular imaging. Regarding the history of CO2, you can imagine that they started to recognize CO2 for imaging since 1920s for visualization of retroperitoneal structures. And in 1950s and 60s, it was used, injected intravenously for identification of pericardial effusion. And it was mentioned that it is safe and well tolerated. And with the advent of digital subtraction and geography in 1980s, it was useful and used as a useful contrast agent intravascularly. Regarding the physics of the CO2, the density and the atomic weight of CO2 is much lower than its body tissues, so that's why it is a negative contrast agent, and it requires a DSA technique with good contrast resolution. CO2 is more soluble than oxygen and nitrogen, and this high solubility of CO2 allows its injection into arteries below the diaphragm without significant pulmonary embolism or gas embolism. And you can imagine that 5 milliliters of CO2 trapped in the right atrium will dissolve in 45 seconds. And a bubble of CO2 in pulmonary outflow tract will disappear in 15 seconds. That's why for multiple CO2 injections, you need a time interval between 3 to 5 minutes to allow and to protect the patient, especially in cases of emphysema and pulmonary hypertension. And this is a way of administering CO2 using this modified plastic bag system with O-ring. And it's a cheap way to administer CO2 rather than the ordinary pressurized cylinder that we are using nowadays. And this is a summary for characteristics between the carbon dioxide and iodinated contrast agents. And you can know that the advantages of CO2, of course, it's in cases of lack of renal toxicity and anaphylaxis. And its low viscosity allows its injection through microcatheters and even with a side port with a catheter and a wire inside, and from the side port of the delivery system in case of EVARs. CO2 has been effective in visualizing all vascular applications, venous and arterial and AV malformations. It can be used in gastrointestinal tract and traumatic bleeding, and it is safe and effective as a flushing medium for catheters, and it's considered to be cost effective compared to non-ionic iodinated contrast medium. The disadvantages of CO2 is that it requires a special delivery system to prevent air contamination, and it has a potential neurotoxicity and myocardial ischemia. So that's why it's contraindicated for thoracic aortography, coronary arteriography, and cerebral arteriography, and it shouldn't be used for abdominal aorta in prone position because its buoyancy characteristics may fill the spinal and lumbar arteries and cause spinal cord ischemia. And it has a relative contraindications to the intravenous use for patients with pulmonary hypertension and chronic obstructive pulmonary disease. And for imaging of CO2, you need a digital subtraction equipment and a CO2 software. And of course, you make use of the stacking software for better quality of images. Like what we can see here. Here is before stacking program, and here is after stacking of the same vessel. CO2 guided EVAR, it has been recently mentioned in prospective study of 72 patients with abdominal aortic aneurysm, and demonstrated that CO2 has an overall sensitivity of 84% and specificity of 72% as compared to contrast agent for detection of endoleaks. And if CO2 is trapped in the ventral portion of AAA, the body position should be changed from side to side to wash out the gas. And of course, you know the explosive delivery of the CO2. That's why we need to clear the catheters with CO2, with 3 to 5 milliliters of CO2 in the catheter to prevent this uncomfortable feeling. CO2 is safe for deployment of the aortic stent graft, and it's useful for diagnosis of endoleaks. And here are some volumes of CO2 for visualization of the main body of the stent and hypogastric vessels applications. And here's our case of 76 years old, hypertensive, non-diabetic. He has recently accidentally discovered AAA while investigating his renal colics, and he has impaired renal functions on conservative treatment. And here's his non-contrast CT scan. And his reconstructed MRI. We started cannulation from the left brachial artery because he has a short neck, so we need to cover the right renal artery with chimney. And then we started routine EVAR with chimney or CHEVAR. The main body is now introduced. We had a CO2 DSA angiography just to make sure that we are in proper position. We started to deploy the main body and the right renal stent. The flow in the right renal artery is okay. We continued EVAR as usual with contralateral limb cannulation, and here is the completion CO2 angiography. We didn't use 1 milliliter of dye in this case. So I just remind you of the Grand Egyptian Museum in Giza. Just make sure to visit it. It will open very soon in a couple of months, and it will be the new crown jewel of Egypt, but it will also be one of the largest, most modern, and most renowned museums in the entire world. Thank you.
Thank you very much, Professor Tamer Fekrey, for your pleasant presentation.